So 70-year-old female, 6 months of shoulder pain. Oh my gosh, you're a wizard. Wow, that was awesome. Thank you. 70-year-old female, 6 months of left shoulder pain. Hasn't really done any PT. Hasn't really had any injections. You know, fairly straightforward medical history other than diabetes. What do you want to know? I mean, the title of the topic kind of gives away if you looked at the first slide, but like, what do you want to know? Let's do the mailbox game. Your neighbor approaches you at the mailbox and is like, my shoulder is killing me, solve my issue right here at the mailbox in the freezing cold, icy, gray, dark and dreary world. What question are you asking? Yeah.
Location.
Yeah. Location, real estate, right? Location, location, location. So it hurts on the side of the shoulder. What else do you want to know?
What makes it hurt?
Oh, so many answers. What makes it hurt? Doesn't, like most patients, they start telling you a story about when they were 12 years old and fell off their bike, and they give you a history of shoulder problems. Not really sure, but it seems like maybe stuff overhead hurts and it wakes her up at night. What were you?
Any injuries?
Yeah.
Recently?
Why do you ask that question?
If you've had the right kind of fall, you can mess things up and hurt.
Yeah, absolutely. And if you read the title slide, rotator cuff treatment, which is, I'm not saying that's what this is, but rotator cuff treatment all hinges on, there's just a different pathway for an acute tear versus a chronic tear. So if someone's recently fallen and has an acute tear or possibly a fracture or whatnot, that is treated very differently than kind of our normal 80 to 90% kind of chronic wear and tear type tear. Okay, good questions. Anything else? What do you want to know? What do you want to know?
Range of motion and strength?
Yeah, so it's a little bit weird to do a physical exam at the mailbox, but we're doing it.
You're there.
So yeah, full range of motion. Strength is hard to assess because when you go to test the rotator cuff, there's a lot of pain and a dramatic response. It's like one of those. It's sometimes very difficult to tell if a patient is in a ton of pain, what is pure lack of strength, and what is, this hurts, I don't want to fight you. Sometimes I tell them that there's a $1 million check in my pocket, and if they can keep their arm up, I will give it to them. I wait until I've seen their MRI to do that. I don't do that when I haven't seen their MRI. And then, it gets them motivated to fight me. And then you can kind of tease that out a little bit better, but at least in my experience, that exam for pain can be challenging. Yeah?
Neck pain and radiating.
Of course, you had to bring the spine into this. Trying to keep spine out of Summit. Brain, spine, and orthopedics for years. But yes, absolutely. No, those are the routine things. No real neck pain, kind of neck range of motion, because we're doing an exam at the mailbox. Doesn't really hurt. No pain down the arms. No history of occipital or lower-based headaches. Kind of no concern there. No numbness and tingling. What else? What else do you want to know? Yeah?
Diabetes. I don't know if it matters how well they manage it.
Oh, it matters. Yeah, absolutely. That's a great question. I think if there is one of the prognosis questions for how they will eventually do in 10 to 15 years, I think if there's one modifiable risk factor that matters, it's probably that, right? If you had an area to focus on. All right, moving on. Okay, we're continuing our mailbox exam. Love it. Inspection's kind of normal. Sometimes even just looking at the shoulder in someone who's had, the cat's out of the bag at this point, a rotator cuff tear, you can actually see if you look at the back of their shoulder or look at their back, you can actually see atrophy in the supraspinous fossa or infraspinous fossa. But that appears normal. She's a little tender over the biceps, full range of motion. She's neurovascularly intact. Empty can is like 4 out of 5, and a positive O'Brien's. Supraspinatus is 4 out of 5. So now what? What do we do? Yeah.
Open the mailbox and see if the imaging's in there.
Yeah. Well, what imaging do you want? This is you have to ask the mailbox for what you want, and then the mailbox possibly delivers in this really weird. We're also still cold.
Yeah, you managed to look at the back of her shoulder, which I thought was cool.
I said that's fair, but also I said theoretically if you did. I don't know where you went in your mind with this mailbox exam. That's fair. This is getting out of control. What imaging do you want?
X-ray, MRI.
Okay. Why X-ray? Why?
You never know if she fell.
Why not just get an MRI? It shows everything.
But does it?
No, that's such a good response. That's my response too. No, I think the arthritis status of this patient is better evaluated, quite frankly, on X-ray than MRI. Yeah, you can see individual cartilage defects, maybe a little bit better, or better, I should say, on MRI than X-ray, but the global picture of the glenohumeral arthritis is way better assessed on X-ray. AC joint pathology is better assessed on X-ray. A small fracture would be better assessed on X-ray than MRI, depending on kind of the type. So yeah, absolutely, X-ray first. And there's some measurements that we make down the treatment pathway. An acromioplasty is something that traditionally we did all the time in every rotator cuff tear. There's a critical shoulder angle that you can measure on X-ray that gives us insight of whether or not we really need to do an acromioplasty. So it's like basics. It's like Vince Lombardi football, basics of alignment, tackling, like just basics of orthopedics. Good. Let's see. So let's do a little theoretical. We're going to do a little deviation for maybe what we typically do with our rotator cuff talk. Let's do a little case comparison. One of the challenges we have with rotator cuff, sorry, I'm like in the way for you guys. I'm so mean. One of the challenges we have with rotator cuff is one, it's not necessarily a challenge. A lot of patients, even with a small full thickness tear, do very well with physical therapy. There are some randomized control trials. The outcomes are only over 2 years, so not long enough that say a small full thickness tear, whether you fix it with surgery or whether you do physical therapy, have similar outcomes. There's a lot of evidence, partial thickness tears, that physical therapy does well. One of the big problems that we have with rotator cuff is about half of full thickness tears will progress over 2 years, and about half the tears that progress will progress asymptomatically. And so sometimes, without even knowing it from a pain perspective, we get into a position where we take a fixable tear to an unfixable tear. Those are the challenges with non-surgery. But let's do this case comparison. We have patient A, B, and C. These are all patients that we have treated over the last 6 months. 45-year-old, traumatic tear, traumatic small tear. Versus kind of a 66-year-old with a bigger tear who's highly active versus a 70-year-old who's in between, a little bit lower activity and kind of an in-between tear. Who do you think of these 3 patients is the most likely to heal and do well?
Without surgery or with surgery?
With surgery. So assuming we did physical therapy, they failed. Well, the one A, we're probably not on a full thickness traumatic tear, we're doing surgery. But with surgery, assuming patient B and C failed physical therapy, what? I'm here.
45-year-old.
Yeah, and who do you think would do the worst? Who do you think would have the lowest chance of healing?
70-year-old.
The 70-year-old? Any takers for the 66-year-old?
Bigger
He's got a
tear.
bigger tear.
Yeah? Yeah, he has a bigger tear. Any other things you would want to know?
Are they smokers?
That's a good question. No smokers. Smokers, I think we've almost completely eliminated in our community.
What is highly active?
Highly active, yeah.
Are they overhead?
That's a really good question. That's pulled. So highly active was pulled from a recent study I'm about to show you that basically involved in any sort of sport, like overhand or using arms, like with a sport like a racket sport would be highly active. If not, then moderate or low activity. So this comparison is something that I think we've struggled a little bit in orthopedics of understanding exactly how, because there are published re-tear rates for rotator cuff, and they vary in the literature. It's like I read an article saying the re-tear rates for rotator cuff range between 4% and 94%. And I was like, I mean, there's such a wide variation of how people do. And so there's this new paper came out. It's been about 18 months. It's out of Korea, but it's Rotator Cuff Healing Index. And this study gives us a little bit better idea of who heals and who doesn't heal. So I know it's a ton of words. Ignore all of this for a little bit. These are just these are where the points are added up, right? And then a certain score, okay? So age over 70 would be 2 points. A big tear would be a couple of points. How much it's retracted would be points. The infraspinatus fatty infiltration right here, like we don't have that for the 3 cases that we discussed, but those are points. Actual bone mineral density is points, and then level of work activity or recreational activity high is 2 points. And so one of the things that we're kind of realizing is that not all tears are created equal, just like not all countries in Europe have the same internal versus external locus of control. But based on this score, we have a healing failure versus healed, right? So we take our first guy, traumatic tear, like basically a centimeter of retraction. He probably has a 0 or a 1 grade, and basically all of them heal, right? And you take our 70-year-old lady, right? 70, if she has osteoporosis, that's 2. She probably wasn't 2 there. That's 5, right? Probably has a little bit of supraspinatus atrophy, so that's 6, 7, 8. So you take an 8, right? Just going from a 0 to an 8 on the score, like 18 failed and 7 healed. And so you can very quickly, we take our 66-year-old patient, 2 points here because it's a large tear, another point, that's 3 because it's retracted. You know, I don't have his MRI, so we don't know if supraspinatus atrophy, but 4 or 5, if he has a lot of atrophy, 6, 7, 8, we're here again. If he doesn't have atrophy, we're somewhere in here where it's like, 60 out of 71 of those patients healed. And so this study has changed the way that Carolyn and I look at rotator cuff pathology. And it also has changed the way that we augment for rotator cuff pathology. I've shown this series of slides before. So this is a patient that, this is the counter argument to do physical therapy for all full thickness tears, right? I think that there is a place for physical therapy, certainly for partial thickness tears and for small full thickness tears. And some of those patients do great, and the studies are very supportive of doing that. This is kind of the other side of the coin, and that is this patient. The image on the right is how he initially presented. Didn't see me first. And then this is how he came and saw me after a ton of injections and 2 years later. And we can kind of see the progress and think about that score, right? This is torn. I don't have the best. This is torn. I don't have the best slice of it being full thickness, but I promise it was full thickness on one of the slices. This is kind of where the tendon is now, right? So if you think about the amount of retraction and the A to P size, like of the tear, we're adding 5 points to this patient's score, giving it a way less likely chance to heal. And so this is the subscap before. Here's the subscap now, kind of hanging out there. The biceps tendon looks like it's out of the groove. And then this is another important slide. You can kind of see how much, when the tendon's not hooked up, we start to get fatty infiltration here. And we've taken a tear that, probably would heal. I don't have this patient's like Rohe score is what we call that study. I don't have this patient's Rohe score, but certainly you would, if you're playing the odds, you'd much rather treat this patient with a full thickness tear than treat this patient. I think it's 18 months to 2 years between these two, and probably, 4 or 5 injections. So what do we do? The question then is like, what do we do with the patient that is, 65, bordering on 70, has the Rohe score is starting to climb up. What do we do with that patient in the setting of no arthritis, right? So they have shoulder pain, they've tried some physical therapy, it's not helping them. What do we do with those? Because it seems so aggressive to replace the shoulder. It's sickening to think about the percentages here. I mean, not that this is 100% generalizable to our population. It's a Korean study. But when you start to think about anything kind of below this line, kind of 7, a Rohe score of 7 seems to be a cutoff between, all right, well, we get about 2/3 of them to heal. That seems reasonable. But when you start to talk about doing a surgery where less than half heal, it starts to get harder and harder to want to do surgery. So I'll explain this slide. Rotator cuff problems inherently are biology problems. And so one of the things that I've always wondered about rotator cuff surgery in my training is like, why we're taking a tendon that chronically tore, which means the tendon isn't healthy, which means the bone probably isn't healthy, and then we're either opening them up or putting a scope in, and then we're reattaching this same diseased tendon back down to the bone. And then we're not having them move for like a couple of months, and then we're hoping that diseased tendon healing back to diseased bone kind of solves the problem, right? And so in orthopedics, we have been trying to augment with biology really since the beginning of time. This is actually, I'm glad Devin's here. This is Arthrex cuff mend. Devin, you want to talk about this for a little bit? You're the cuff mend expert. That's what Jonathan tells me.
Yeah, right. So we're taking like a human dermal allograft.
Yeah.
And placing it, superiorly upon the rotator cuff.
Yeah. So we've already healed the tendon down, and then we're adding the dermal allograft to the cuff, right?
And so when we attach it, it gives it time zero strength.
Yep.
It gives it a better chance to heal. It incorporates fully into the rotator cuffs.
Yeah, and there's a lot of data to suggest that this is one potential option, is allograft. Good. This is actually xenograft. This is a porcine xenograft, so taking animal tissue and essentially doing the same thing where you're putting this patchwork over top. One of the things about these patches are they do give a little bit of time zero strength. There's been autograft options described. This is the biceps tendon. We frequently, cut out a portion of the biceps tendon. This is saving that tendon and smashing it in a little press to get it to flatten out and be like this, and then putting this autograft over top. The other things that have been tried are things like PRP or stem cells or bone marrow aspirate or BMAC. And we're starting to get a lot more of the data for these types of solutions. And so let me just show. Okay, this is just a little 3-minute walkthrough of what a rotator cuff looks like. So that's the cut biceps tendon. Here's the attached infraspinatus kind of coming around the back. You can see there why infraspinatus does external rotation. It actually kind of comes around the back of the shoulder. We're cleaning off all this bursal tissue. It's retracted enough. We cannot fix this tendon under a bunch of tension or it won't heal. Again, infraspinatus back here. That's the footprint where the rotator cuff is supposed to attach. Here's the supraspinatus into a little bit of the infraspinatus up here. We're just trying to kind of assess it, clean it off, decide where it goes to. These are tapes that we've passed through the rotator cuff. I'm going to show another tape passing. So we have a little cannula out here that helps us get access. Oh, come on, Gary, pass the tape already, buddy. My gosh. So here's a little passer here, right? You can see that passer going over. It has a needle loaded with the tape, and it shoots up, and then this device grabs the suture. So we're passing that suture through the cuff and kind of pulling it there. And so we get this suture configuration. We put anchors kind of all the way medially, and then we're going to get this suture configuration built like this and pull it down laterally and fold the rotator cuff over. This is a little live surgery look. So that's our kind of one stitch knotless mechanism. This is the tendon pulled all the way up against the other portion of the tendon that's still attached. This is what it's like, I say it looks like a drywall anchor all the time, and that's because it's exactly what it looks like. Oh my gosh, Gary, put the anchor in. Come on, buddy. Go.
Those are permanent anchors, right? They're not soft.
Yeah, we really hope so. Yeah. That's a good question, though.
What are they made of, I guess?
So there's a couple. There's PEEK, which is a hard plastic. There's some biocomposite, which are designed for the bone to kind of grow in. There's all suture anchors as well, which is kind of one of the trendy things to do, all suture anchors that take a little minimal footprint of bone. These are typically, the sizes are like 4.75. You can even get 5. So, we're talking about like 0.5 centimeter wide footprint. So here's our rotator cuff fixed, right? And then I think here I show some motion. We want to make sure the whole thing moves as a unit here. Yay. Right? So kind of all healed or all folded together, kind of exactly where we're supposed to be. Anatomic repair. We've roughened up the footprint to cause bleeding. Sometimes we've roughened up the undersurface of the acromion to cause bleeding. And then what we did for this case was a little patch. So it's a little bit hard to see here, and the video's not playing, so awesome. So, it showed a little video and it zoomed in, but basically we took the dermal allograft and attached it medially and then folded it over top of the rotator cuff, and we use a little small anchor to put that in and hold that down. So what's the outcomes? Basically, in this study, again, this is a study out of Korea. There are similar studies out of the United States. There are studies that are also not this promising for patch, whether it be xenograft, allograft, or autograft patch augmentation, but took a average re-tear rate from 39% to 9%, and an improvement in the constant score, which is a patient-reported outcome score centered on pain. And so What the cutoff should be is one of the big questions. Oh my gosh. What the cutoff should be is one of the big questions. The patches are expensive. It's a high cost. It's added time to the case. It's probably a small added risk of complication. But where we draw the line of who we think about augmenting and who we don't, and who we find another solution for, is like one of the kind of hot new topics in orthopedics. Carolyn and I draw a line somewhere in here for who we should augment, and we're moving more and more and more towards augmentation. Devin, in your experience, compared to, how many guys are augmenting now compared to a couple of years ago?
It's definitely growing. Yeah, for sure. It's moving in that direction.
Yeah.
More and more.
Yeah. And like I was always told in residency and fellowship that you never wanted to be you didn't really want to be the first guy to adopt something, because if it doesn't work, then that's trouble. But you definitely don't want to be towards the back half of people that adopt something that's really promising. There's a lot of promising data behind this. It's an exciting portion of orthopedic surgery. We can take a patient who has a literal almost 100% chance of failure and improve those chances. There's some of these numbers that I think the answer is a reverse based on age. Even if there's a little bit of arthritis, or I think doing the surgery here, it may not matter what you put on the top of the rotator cuff. It may not heal. Yeah.
So you posed that question earlier of somebody who was like 60, 70 years old. Like, what do we do? The replacement seems like a big leap for something we don't need to do. And so my first thought was quality of life. Does this new scoring take in quality of life, or is that?
Yeah,
kind of
that's the constant score, the patient-reported outcome. So it's a questionnaire of I can't remember on the constant score how many. There's like 20 questions, and there is a statistically significant difference in patient's quality of life, aka patient-reported outcome score, in an augmented versus a non-augmented rotator cuff. So yeah, that's something that we're looking at too. Because if it is a 9% re-tear rate, but they're miserable, no one wants that. So yeah, very good question. Any other questions?
Any additional precautions with the dermal graft
No.
being put in place?
No, that's a very good question. Yeah, my standard for large tears is to kind of just to leave them alone for 6 weeks, some kind of gentle pendulums, kind of making sure that the elbow's moving, wrist is moving, hand is moving as much as possible. I try to convince my patients to play video games to get their hands activated as much as possible while they're in the sling. And then for those large tears, kind of just waiting on them a little bit. If you're going to re-tear, it usually happens between the first 6 months to a year. Usually if we can get them out of that challenging period, then we're going to be good. Any other questions?
What about multiple tears?
What do you mean? Like subscap? Well, so if you had a subscap tear, you were eliminated from this study, because a subscap tear is a little bit different. There wasn't anyone in this study that had a teres minor tear, and so there were combinations supraspinatus and infraspinatus, aka multiple tears. I think if you'll look I don't want to have to pull up the video again, but if you go back to the video, that was a disaster. But if you go back to the video, you would be hard pressed in surgery to tell the exact delineation between supraspinatus and infraspinatus. Their tendons kind of run together. So yeah, some of these were multiple tear because you had the anterior to posterior footprint is more than 2.5, which by definition means you've gone into the infraspinatus, or you've gone into the supraspinatus if the infraspinatus is all off. Yeah.
If you're going to wait for 6 weeks, is it a clinical assessment, or do you have to get some sort of imaging at the end of 6 weeks to see if this is progressing or not?
No, so typically I don't get follow-up imaging unless there's like a problem or a patient has pain, which is like way outside kind of the normal. The 6 weeks is kind of just essentially an evaluation based on kind of history and other people's protocols. And I mean, the physical therapist can tell you anytime protocols are studied, it's always like, well, maybe there's a difference, but also maybe not. And so it takes about 12 weeks for the tendon to heal. There's a certain portion in any tendon healing, like course, where it's stronger at time 0, and then the tendon undergoes some remodeling, and then it's actually weaker at 2 or 3 weeks. And then it makes a rebound, and at 6 weeks, you're stronger than when you originally were. And so some healing has started to take place. So it's probably centered around that biology, the thought process. The other thing is we want to make a smooth landing. We don't want to stay here for 3 months until the tendon is healed, and then be like, oh shoot, we can't get the motion back, and then oh yeah, we forgot about strength. Now they're super weak, and now we got to build their strength up. We try to just make a smooth landing and start our descent, right? Start our approach on motion as soon as we can, and then at the same time start to do some like light active assisted range of motion at 6 to 8 weeks. I don't know, are most protocols active assist range of motion 6 to 8, guys? Is that what most people are doing? Yeah, like maybe a large chair, you'd probably let it sit for a little bit longer. But we want to start strengthening, active assisted at 6 to 8 weeks and kind of progress from there. Because we want healing to happen, we want motion to happen, and we want strength to happen. And we don't want motion and strength to affect healing. And so that's kind of one of the other reasons why, we're moving towards biologic augmentation, which makes sense. If you think about how a rotator cuff looks, attaching a diseased tendon, reattaching a diseased tendon to diseased bone that has already torn over the regular course of life, it's like, is this really the best we have? And the answer is no. I think it's the future. So
It'd be really nice to see a lecture on how the biologic gets integrated into your own tissues.
oh, yeah, we can do that next time. Okay. All right, questions? Any other questions? All right, awesome. If I make these boring enough, I think they won't have me do as many of them in a row.